Hello, this is Dr. Gary Siskin, and today I'm going to be speaking about paracentesis procedures. This lecture is the first in a series of lectures entitled In the Trenches. My goal here is to highlight the procedures that interventional radiologists do every day that just aren't exciting enough to warrant a lecture at some meeting or educational program that you're attending. So where else to start but with paracentesis procedures? Like all things we do, this starts with the patient, and there are many patients that have the potential of developing ascites. The list of potential causes is long, and it includes everything from cirrhosis and hepatitis to heart failure, cancer, and a whole host of more rare conditions which can be associated with ascites. About 85% of patients with ascites in the United States have cirrhosis, and only 15% have a non-hepatic cause of fluid retention. In cirrhosis, ascites occurs at a rate of 7 to 10% per year, and within 10 years of the diagnosis of cirrhosis, approximately 70% of patients will have developed ascites. The survival rates in patients with cirrhosis who develop ascites is 85% and 56% at 1 and 5 years respectively. Cancer is the second most common cause of ascites and accounts for 10% of all cases. It's most commonly associated with ovarian cancer, but is also associated with a list of other cancers including colorectal, pancreatic, uterine, gastric, and primary peritoneal cancers, as well as extra-abdominal tumors such as lymphoma, lung, and breast cancer. Ascites can be the presenting sign or symptom of malignancy in about half of the cases, and patients with gastric and ovarian cancer are more likely to have malignant ascites at the time of their first diagnosis. The reasons why ascites occurs in these patients is very complex. Patients with compensated cirrhosis have impaired renal sodium metabolism, which can actually be detected before ascites develops. Over time, patients become unable to excrete their regular sodium intake, which leads to sodium and water retention with ascites. This is unrelated at this time to the renin, angiotensin, and aldosterone systems and the sympathetic nervous system. Initially, in compensated cirrhosis, the shift of fluid is compensated for by an increase in lymphatic drainage. And as cirrhosis advances, the escaping fluid overwhelms the lymphatic return and more fluid accumulates in the peritoneal cavity. And then patients develop uncompensated cirrhosis. And here's where it really gets complicated. We know that cirrhosis of the liver can lead to fibrosis and portal hypertension. One consequence of portal hypertension is that it can result in mesenteric arterial dilatation. This is due to backwards transmission of increased pressure leading to increased shear stress in these vessels. There's also increased translocation of bacterial and bacterial products from the gut, and these have direct vasodilatory properties. And finally, nitric oxide is released and contributes to vasodilatation as well. These vasodilators can pass through portosystemic shunts and cause systemic vasodilatation. The body senses the decrease in effective arterial blood volume and tries to address it with vasoconstriction, which is accomplished in two different ways. First, there's activation of the renin, angiotensin, and aldosterone systems, and second, there's stimulation of the sympathetic nervous system. The vasodilatation and underlying portal hypertension can cause increased permeability of the mesenteric capillaries, which can then lead to the formation of ascites. Another effect caused by the activation of the renin, angiotensin, and aldosterone system is sodium retention, which can also contribute to the development of ascites. So the bottom line here is that the mechanism for ascites formation in compensated and uncompensated cirrhosis is complicated. Malignant ascites is probably due to a combination of two different mechanisms. First, VEGF expressed by the primary tumor is a major contributor to tumor neovascularization and increased capillary permeability, which in turn contributes to ascites accumulation. And second, tumor cells in the peritoneal cavity directly obstruct lymphatic channels, which can lead to impaired fluid drainage from the peritoneal cavity and increased ascites. So how are these patients managed? Well, this tends to pass through first-line, second-line, and third-line management. The cornerstone of first-line treatment is alcohol abstinence. Abstinence can result in dramatic improvement in the reversible component of alcoholic liver disease. Ascites may resolve or become even more responsive to medical therapy if the patient abstains from alcohol and gives this whole thing time. So if a patient has alcoholic cirrhosis and ascites, one of the best things you can tell the patient is to stop drinking. Dietary sodium restriction is also important. The goal here is to limit daily sodium intake and increase urinary sodium excretion by using diuretics. And this will induce a negative sodium balance and lead to fluid loss and weight loss. The sodium restriction leads to weight loss since fluid follows the sodium passively. Diuretic therapy is also an important part of first-line treatment. Combination therapy with spironolactone and Lasix is commonly used. Spironolactone is an aldosterone antagonist, and this drug prevents the reabsorption of sodium at the distal tubule under the unopposed action of aldosterone. It's usually administered as a startup dose of 100 milligrams per day and can gradually be increased to up to 400 milligrams per day. Lasix is a loop diuretic, and this drug prevents reabsorption of sodium at the loop of Henle. The starting dose is 40 milligrams per day, which can be increased to 160 milligrams per day. Diuretics and dietary sodium restriction have less efficacy in malignant ascites than they do with cirrhotic ascites. They only provide symptomatic relief in about 40% of patients with malignant ascites. So when does IR get involved? Well, IR tends to get involved as part of second-line treatment of these patients. In this phase of treatment, the first thing to consider are the drugs that the patients are on. Antihypertensive drugs like beta blockers and ACE inhibitors should be avoided in these patients. Remember that vasoconstriction occurs in order to compensate for the vasodilatation occurring in portal hypertension due to nitric oxide and other vasodilators. Survival is decreased in patients with a lower mean arterial pressure. NSAIDs should also be avoided in these patients because they can reduce urinary sodium excretion in patients with cirrhosis. An early referral for liver transplant is also an important part of treatment. Liver transplant is the ultimate treatment for cirrhosis and refractory ascites occurring due to cirrhosis. Because refractory ascites is associated with a particularly poor prognosis, immediate referral to a liver transplant center is recommended. Once a patient develops refractory ascites, the survival rates decrease, with a 50% survival at 6 months and 25% survival at 12 months. Liver transplants associated with 2-year survival rates of almost 85%, which is why prompt referral is indicated. We might see these patients when they come to us for TIPS procedures a little bit later in the course of their disease, but I'm going to hold off on this for now. We first tend to see these patients for paracentesis procedures. At this point, I'm going to acknowledge that yes, many people can do a paracentesis, and turning to IR seems like overkill. I would encourage you to not discount your comfort and expertise with image-guided procedures. This stuff makes a lot of people nervous, and if you want to be seen as the expert, you have to acknowledge that not everything is going to be exciting to you all the time. In addition, it's easier for us to add another procedure to our day than it is for a non-proceduralist to do one procedure. And finally, in my experience, patients tend to like the service that they receive in interventional radiology as opposed to just be lined up in the office of a gastroenterologist or a surgeon. So let's talk first about a diagnostic paracentesis. In this particular case, we're just going to pull off some fluid to better understand what's going on with the patient. And obviously, once we pull off some fluid, we're going to look at it. And it has the potential to look several different ways as outlined in this table. Most of the time it's clear or yellow, but it can be cloudy in the case of infection. It can be blood tinged due to mild trauma. It can be grossly bloody due to malignancy or abdominal trauma, or it could be chylous. And I want to just take a minute to talk about chylous ascites, because this is a rare form of ascites that results from the leakage of lipid-rich lymph into the peritoneal cavity. In the setting of portal hypertension, chylous ascites may be due to increased production of hepatic lymph due to increased venous pressure, rupture of dilated lymphatics due to increased lymphatic pressure, and potentially right heart issues leading to central venous hypertension. In patients without portal hypertension, chylous ascites can occur due to the formation of megalymphatics with exudation of lymph, or fibrosis of lymph nodes with flow obstruction and leakage in the setting of cancer. Labs are also going to be an important part of a diagnostic paracentesis. Routine labs usually include a cell count and differential, albumin, and total protein, with other labs being obtained if clinically warranted, or the referring physician or you as the performing physician has a suspicion of another condition such as infection, cancer, or something else that could potentially be causing the ascites. One test that should be done is the serum ascites albumin gradient. The albumin concentration can be used to confirm the presence of portal hypertension by calculating this gradient. And all you're really doing is subtracting the serum albumin from the ascites albumin. And this gradient has been proven to categorize ascites better than any previous criteria. If this gradient is greater than 1.1, the patient has portal hypertension with approximately 97% accuracy. And if the gradient is less than 1.1, the patient probably doesn't have portal hypertension related to ascites, and another cause of the ascites should be determined. Sometimes we might order cytology for the fluid we obtained. Remember, fluid cytology is only positive in the setting of peritoneal carcinomatosis. Patients with peritoneal carcinomatosis usually have a history of breast, colon, gastric, or pancreatic primary carcinoma. The sensitivity of cytology is over 96% if 3 samples from 3 different paracentesis procedures are sent and processed promptly. The first sample is positive in 83% of patients. Frequently, and it does seem that this occurs at off times, we may be asked to rule out SBP, or spontaneous bacterial peritonitis. This is the most common source of infection in patients with cirrhosis. It's associated with high mortality rates of 32% at 1 month, 26% at 3 months, and 60% at 12 months. This occurs because patients with liver dysfunction have abnormalities in host defenses. Patients with cirrhosis are more vulnerable to bacterial translocation due to intestinal bacterial overgrowth. They also have increased interstitial permeability and altered immune defenses, which increase the susceptibility to SBP. The most common organisms are gram-negative bacteria, including E. coli. Early diagnosis is important in these patients because it can reduce mortality. Early paracentesis, meaning less than 12 hours, versus delayed paracentesis, meaning 12 to 72 hours, is associated with reduced mortality, and this is 13% versus 27%, shorter ICU stays, and shorter hospital stays. And in fact, each hour of delay is associated with a 3.3% increase in in-hospital mortality. In addition, every 1 hour delay in administering antibiotics in patients is associated with a 1.86 times increase in in-hospital mortality. Clinically, the absence of abdominal pain is 94% sensitive for ruling out SBP, and fever within 24 hours of presentation is highly specific for SBP. The diagnosis does require an evaluation of the acidic fluid. Peritoneal infection causes an inflammatory reaction and increased number of neutrophils in the fluid. The diagnosis requires a PMN count of greater than 250 per milliliter. The fluid should be cultured in aerobic and anaerobic blood culture bottles prior to starting antibiotics. Bacterial growth occurs 80% of the time when collected in culture bottles, compared to only 50% when collected in other containers. Broad-spectrum antibiotics is going to use for treatment, and albumin is also going to be used. Albumin plus antibiotics has been demonstrated to reduce the incidence of renal impairment and reduce in-hospital mortality from 29% to 10% compared to antibiotics alone. The use of albumin in this setting has been supported and has demonstrated protective effects on renal function and mortality. And patients with SBP and a serum creatinine greater than 1, a BUN greater than 30, or a total bilirubin greater than 4 should be given 1.5 milligrams per kilogram of albumin within 6 hours of diagnosis and an additional 1 milligram per kilogram on day 3. We also see patients for therapeutic paracentesis, and in this context, I want to talk about how the procedure is performed. Therapeutic paracentesis is an option for patients with refractory ascites, and this is defined as fluid overload that's unresponsive to sodium-restricted diet and high-dose diuretic treatment, which means spironolactone at 400 milligrams a day and Lasix at 160 milligrams a day, or ascites that recurs rapidly after paracentesis. Over 11% of patients with ascites will develop refractory ascites. These patients have a poor quality of life because the ascites causes many symptoms, including immobility, bloating, early satiety, and the development of various hernias. While large volume paracentesis can definitely help patients feel better, it's important to remember that it doesn't change the pathology, and therefore recurrence should be anticipated. When getting a patient ready for paracentesis, remember that there's no data to support the use of FFP prior to paracentesis, but you can consider giving platelets if the platelet count is less than 40 to 50,000. In terms of where do we put the needle into the abdomen, paracentesis from the midline position has generally fallen out of favor, mainly because of increased thickness of the abdominal wall at the midline compared with the more lateral positions, especially in obese patients. A lateral position at the mid-axillary line with ultrasound guidance will work for most patients because you can use ultrasound like this image and see where a large pocket of fluid is located and choose your site appropriately. With ultrasound, you can confirm the presence of ascites. You can determine the trajectory and depth for needle access. And to reduce the incidence of solid organ or bowel injury, the anticipated point of needle entry and its likely trajectory should be carefully mapped out with ultrasound. You need to have some idea how far it is to reach the fluid and how far it is to reach the bowel and stay in between those 2 points. You can also try to avoid superficial blood vessels, such as dilated epigastric veins, which you can usually see, and the inferior epigastric artery, which runs about 5 to 6 centimeters lateral to the midline on each side. In terms of lab data, patients undergoing serial paracentesis procedures should probably be tested only for cell count and differential. Bacterial culture is not necessary in asymptomatic patients, and repeating the albumin gradient on fluid removed therapeutically is also usually not needed. A therapeutic paracentesis is felt to be safer and more effective than diuretic therapy. It has a lower incidence of renal dysfunction, electrolyte abnormalities, and fewer hemodynamic consequences. Survival rates, however, do not differ between diuretics and serial paracentesis. So what can go wrong? Well, the good news is that most paracentesis procedures occur without any complications. The overall complication rate has been reported to be as high as 10%, but these are generally minor and self-limited. The complication rate is higher when ultrasound isn't used. I do want to spend a little bit of time talking about paracentesis-induced circulatory dysfunction. This is technically defined as an increase in plasma renin activity of greater than 50% over baseline, up to a final value of 4 nanograms per milliliter per hour on day 6 after paracentesis. The severity of this directly depends on the amount of fluid removed. This generally occurs when more than 5 liters of fluid is removed, and there's minimal risk when less volume is removed. After a large volume paracentesis, intra-abdominal pressure decreases, which transiently increases venous return and cardiac output, which suppresses the renin, angiotensin, and aldosterone systems, and also suppresses the sympathetic nervous system. This induces an excessive drop in peripheral vascular resistance while increasing intrahepatic vascular resistance, which results in blood pooling in the mesenteric vasculature with vasodilatation. This in turn activates or reactivates the renin, angiotensin, aldosterone system and sympathetic nervous system to levels above baseline. And this can lead to rapid reaccumulation of ascites in addition to hepatorenal syndrome with renal impairment and ultimately shorter survival. Symptoms may include discomfort, shortness of breath, and decreased appetite. The recommendation is to infuse 6 to 8 grams of albumin per liter of ascites removed when performing a paracentesis of greater than 5 liters. This works because albumin increases plasma oncotic pressure. This expands the plasma volume and prevents the decrease in effective blood volume. Albumin also reduces the increase in plasma renin activity after paracentesis and prevents hyponatremia and deterioration in renal function. Overall, albumin reduces the incidence of paracentesis-induced circulatory dysfunction from 80% to levels as low as 15 to 35%. However, there are no large randomized controlled trials showing a survival benefit associated with its use. Bleeding is another rare risk of paracentesis. Most bleeding is self-limited, but more severe bleeding can result in an abdominal wall hematoma or pseudoaneurysm formation if the inferior epigastric artery is injured. Intraperitoneal bleeding is possible, but is very rare. I know we'd like to try and prevent this from happening, but routine coagulation studies don't reflect the bleeding risk in patients with cirrhosis because of a balanced deficiency of procoagulants and anticoagulants. Patients with renal failure, however, may have a higher risk of bleeding with a paracentesis. The routine prophylactic use of FFP or platelets before paracentesis is not recommended. Other complications include a dry tap. A failure to drain ascites may occur because the ascites doesn't actually exist, or because of bad needle insertion point or trajectory, which can also result in other complications. Fluid leaks can happen in 5%, infections are rare, and bowel perforation is a rare complication as well. Over time, the efficacy of paracentesis decreases, and the risk for complications increases. Moreover, there's a decrease in quality of life associated with intermittent paracentesis. And this is another opportunity for interventional radiology because we perform TIPS procedures, catheter-based drainage procedures, and even peritoneovenous shunts. In terms of TIPS, several studies have shown that TIPS provides significantly improved control of refractory ascites in cirrhotic patients compared with paracentesis. TIPS should be considered in appropriately selected patients who meet the criteria that's similar to those in published randomized trials. More information about TIPS can be found in a future TIPS lecture. Some will consider placing non-tunnel drainage catheters for drainage of ascites. The problem here is that these have significantly higher rates of associated infections and peritonitis and are only recommended for patients with very short life expectancy. Tunneled catheters can be considered in these patients, and pictured here is the Pleurex catheter as well as the catheter from Rocket Medical. These allow patients to control their ascites at home with or without the assistance of a caregiver. They also lead to fewer clinic and hospital visits. They also allow for more frequent and smaller volumes of drainage, which provides for better symptom management. And finally, they can potentially be used to facilitate the infusion of intraperitoneal chemotherapy or targeted therapy in the event of malignant ascites. Many studies have been performed showing efficacy of these catheters for malignant ascites. Fewer studies have been done looking at these catheters for end-stage liver disease, but success has been reported. And up to 90% of patients have their catheters in place and functioning at the time of death, which demonstrates the durability of this option. Risks include peritonitis, which can happen in 4% of patients, and other complications include cellulitis at the catheter site, bacteremia, leakage or bleeding from the catheter site, catheter occlusion, and fatal hypotension. Finally, peritoneovenous or Denver shunts should be discussed in the context of this lecture. These are catheters that connect the peritoneal cavity to the central venous circulation, and they have the theoretical benefit of eliminating protein and fluid loss by returning ascites to the circulation. They can be considered for patients with refractory ascites who aren't candidates for paracentesis, transplant, or TIPS, and they can be used in cirrhotic, malignant, or chylous ascites. The shunt itself is made of two silastic tubes connected by a compressible pump. The end hole catheter is placed in a central vein, and the fenestrated catheter is placed in the peritoneal cavity. The pump is valved, and the valve opens once the pressure differential is greater than 3 millimeters of water. The valves serve to prevent reflux of blood into the peritoneal cavity. There are several contraindications to placing these shunts. They shouldn't be placed if there's concern for volume overloaded, for post-procedure shunt occlusion or malfunction, for post-procedure DIC, and for post-procedure sepsis. The complication rates of these shunts are higher than other options to manage malignant ascites, and the main complications include shunt occlusion, meaning the catheter kinking, venous thrombosis, or fibrin sheath formation, DIC, infection, and volume overload. These shunts can lead to immediate symptomatic relief and improvement in quality of life in most patients with malignant and chylous ascites. Success with cirrhotic patients has been reported as well, and the outcomes have improved a lot with percutaneous placement of these shunts compared to surgical placement. In conclusion, paracentesis is one of those procedures that we just do and don't think too much about. But I would advise you to not discount the service that you're providing to these patients and their referring physicians. They appreciate it, and the simple paracentesis can often lead to an opportunity to perform more advanced procedures in these patients.